Hi, I'm Mimi Boo. I'm a pediatric pulmonologist, and I am on the neuromuscular team at Stanford Children's Hospital and Stanford University. So today I'll be talking about respiratory care in pediatric patients with SMA, which will be followed by Dr. Cow, who will speak about adults, care in adults. So I have no disclosures. So the respiratory, I'll first cover the respiratory sequela in patients with spinal muscular atrophy. So the chest wall is surrounded by muscle, and in patients with SMA, the muscle is weak. And the normal respiratory muscles are the intercostal muscles here, and then the diaphragm, which is not pictured underneath these, underneath the chest wall. And these are the main muscles of inspiration. And so because these muscles are weak, this affects a patient's ability to breathe. Normally, the lung parenchyma wants to collapse and recoil in its natural state. So it wants to come in, whereas the chest wall itself wants to spring out. And so because the chest wall is weak, it isn't able to counter the inward drive for the lungs to collapse. So then it leads to chest wall distortion and then leads to the classic phenotype that's seen in non-sitters in SMA, which is a bell-shaped chest. The weak chest wall also leads to underdevelopment of the chest wall itself, and then over time can lead to thoracic and lumbar scoliosis, pectus, which is sternal malformations, pectus carinatum or pectus excavatum, and the weak muscles themselves also impair cough. There is also airway obstruction. So this is from retained secretions. So because of this impaired cough, patients are not able to mobilize their normal secretions. The lungs are always producing mucus as part of the normal immune system of the lung. And there are also normal secretions in our mouth as well with the saliva. And due to weak swallow or weak pharyngeal muscles, this also causes buildup of secretions in the pharynx, which leads to obstruction. The tone in the neck can also be low, which can cause airway obstruction as well. The lungs themselves can get injured. This occurs due to secondary causes of airway infections because the cough is weak, or from aspiration because the swallow is weak. And recurrent injury causes remodeling of the airways or the lung parenchyma, which then affects lung function. So what are the symptoms? So in terms of chest wall distortion, the symptoms can be discomfort with positioning, symptoms of shortness of breath. And in terms of the inadequate breathing or respiratory insufficiency, some of the signs are tachypnea or abdominal breathing on exam. The signs of excessive carbon dioxide, because the CO2 gets retained, includes frequent awakening during sleep, sweating during sleep, morning headaches, restlessness, daytime fatigue, fading in the afternoon, nausea, and then the signs of having insufficient oxygen drawn in by the lungs is poor growth and cyanosis. Some of the symptoms of ineffective cough include the patient having the sensation of inability to clear their secretions, having noisy breathing, chronic cough, recurrent respiratory infections, which then, and with the chronic cough can lead to bronchitis and pneumonia. So this slide tries to capture the progression of respiratory sequelae in untreated patients. So this is based on the natural progression studies. So in non-sitters, the mortality was estimated to be about 50, or has been described to be about 50% at 12 months of age and about 70% by 24 months of age. In the natural history studies, they have shown that 100% of patients will need some form of assisted ventilation, and about 40% need more than 16 hours a day of assisted ventilation by 12 months of age, and 50% need more than 16 hours a day of assisted ventilation by 24 months of age. In sitters, it's been described that 46% need some amount of assisted ventilation by the time they're 6, and contrary to non-sitters, in sitters, about 10% need more than 16 hours a day of assisted ventilation. And a recent paper by Dr. Trucco, which has just been accepted, showed that the FVC declines by 1% per year between the ages of 5 to 13, and then plateaus after 13 years of age. So as a clinician, I've been interested in what are the effects on the pulmonary sequelae and pulmonary phenotype in patients who've been receiving SMA modifying therapies. So for nusinersen, and here I share data on patients who were treated under 7 months of age. 22%, only 22% needed assistive ventilation more than 16 hours a day at 24 months, which is in contrast to the 50% in the natural history trials. And then 25% didn't need any form of assistive ventilation by 12 months, which is really remarkable. And beyond that, with gene replacement therapy for patients who were treated under 8 months of age, 70% did not need any assistive ventilation by 24 months, after 24 months of treatment, post-treatment, and 0 patients needed more than 16 hours of assistive ventilation at 24 months post-treatment. In the gene replacement patients, these are the patients under clinical trials, so we have yet to see what's happening with real world data. So we've covered the respiratory sequelae, and so now I'd like to cover how to assess for this. And so in this table, I tried to show the assessment on the left side and when to consider intervention if you find an abnormality during your assessment. So in physical exam, the things that we look for that we may consider an intervention would be chest wall deformity, scoliosis, or poor growth in terms of weight. In terms of lung volume measurements, we can measure vital capacity, either by forced vital capacity or slow vital capacity. And normal is to be above 80%, but we usually will start some type of intervention when it's less than 60% predicted. We also can measure respiratory muscle strength. And the different measures include maximal inspiratory pressure or sniff pressure. These are both measures of inspiratory respiratory muscle strength. And we intervene if the measurement is greater than less than 60 centimeters of water pressure, because usually your strength should be stronger than that. And then the measures of expiratory muscle strength include peak cough flow and maximal expiratory pressure. So if it's less than 270 for a peak cough flow or less than 60 centimeters of water for MEP. The way we measure respiratory sufficiency and gas exchange includes pulse oximetry, which normal is greater than 94%. We also recommend polysomnograms and will intervene if the PCO2 is greater than 50 for more than 2% of the sleep time, or the oxygen saturation is less than 88 for more than 2% of the sleep time, or more than for 5 minutes, or the AHI is greater than 5, which is the apnea-hypopnea index. For blood gas, we will intervene if the PCO2 is greater than 50, bicarbonate if the bicarbonate is greater than 30. And then for chest imaging, we're looking for bell-shaped chest, lectasis, abnormal opacities, or scoliosis. In this table, I try to capture when we do these assessments, depending on the patient's phenotype. So in terms of clinical assessment and physical exam, it's recommended to be done every 3 months for non-sitters and every 6 months beyond that, and the same for sitters, and walkers is where they should see a pulmonologist when they're symptomatic. For pulmonary function, we recommend for non-sitters every 6 months, starting at 5 to 6 years of age, and that's true for sitters as well. And then in walkers, we recommend lung function to be done once they're symptomatic or for pre-anesthesia planning. Polysomnograms, we recommend it to be done as baseline for both non-sitters and sitters, and then yearly or when we're doing anesthesia planning. For walkers, we recommend it to be done as needed and for pre-anesthesia planning or when the vital capacity is less than 60%. And chest imaging is recommended yearly for all phenotypes to look for scoliosis and other chest abnormalities. And thank you very much for listening to this presentation. Here's my contact information.
Hello, my name is Dr. Michelle Kao, and thank you for having me. I am a clinical associate professor and an adult pulmonologist, and my specialty is in the respiratory management of neuromuscular disease. I have no disclosures. The goals of respiratory intervention include three main pillars. The first one is to preserve lung function. This is to normalize oxygen levels in the blood as well as carbon dioxide, and also to improve chest wall and lung development. The second pillar is to improve quality of life, and this is to facilitate the care at home, to optimize sleep, and to decrease the work of breathing, meaning to rest the muscle so that strength can be used elsewhere. And last but not least, to help breathing and coughing during illness. This can help reduce hospitalizations as well as prevent tracheostomy. There are three main categories that where respiration can be affected, and there are interventions that are associated with this. So this is sort of a summary slide here. So the first category is that patients can have nocturnal hypoventilation, and the treatment would be using a non-invasive ventilator device. We call it nocturnal non-invasive ventilatory support. The second category is daytime hypoventilation, and the treatment would be using a daytime non-invasive ventilation device or invasive approach with a respirator. And the last category, which is also very important, is impairment with airway clearance. And we recommend the use of manual and mechanical cough assist. And I'll go over those in detail. In terms of respiratory interventions, there are two main categories. There's the assistive ventilation and airway clearance. So for assistive ventilation, it's called non-invasive positive pressure ventilation, or NIV, and this is to improve gas exchange, CO2 and O2, as well as prevent or minimize chest wall distortion. It can really relieve the work of breathing, and we recommend the use of advanced non-invasive positive pressure modalities. CPAP should not be used in non-sitters and non-walkers. CPAP can be used selectively in walkers if they have strictly just obstructive sleep apnea. Oxygen alone should never be used for long-term support. In the acute setting, it can be used in conjunction with the NIV device. For airway clearance, there is manual mechanical. So manual consists of oral suctioning, chest physiotherapy, and airway hydration. For mechanical, this is where we use the mechanical inexsufflation, otherwise known as the cough assist. There's also, we can use a ventilator, and we use it for breath stacking. And both of these have the added benefit of lung volume recruitment and expansion in addition to airway clearance. So in terms of non-invasive ventilation devices, there are two categories. One is for the isolated sleep hypoventilation, and the other category is for patients who suffer from daytime hypoventilation or respiratory failure. In the first category, these are called the respiratory assist devices, or RADs. These are your bilevel PAP devices, specifically with a backup respiratory rate. This is important because this is what helps to support ventilation during sleep. The recommended modes for these devices are, you may be familiar with this. These are the bypass. Again, ST is spontaneous time with a backup rate. Also, the more advanced PAP devices known as AVAPs or IVAPs, these are the most advanced BiPAP devices in the market. In terms on the other category, these are the portable ventilators or respirators that we use in the home setting. And some of these are the brand names. These are just the ones that are available in the United States. Trilogy, Evo, Astral, Voxen. These are the same modes as the RAS devices, but the added feature is that they have mouthpiece or SIP ventilation for use in the daytime as well. So I get this question a lot. How do I choose the correct NIV device and mode for my patient? So the answer is that the device and setting depends on the severity of the disease. So for isolated sleep disorder breathing or an FVC of greater than 50% predicted, recommend the respiratory assist device. We start with low pressures and acclimate or escalate up so patients can get used to it. So for example, a starting pressure could be an IPAP of 10, EPAP of 4, and a backup rate of 12. The goal is to achieve a tidal volume of 8 to 12 mLs per kilo, and this is ideal body weight. And the goal eventually is to use a very high pressure support to support ventilation. This can be done in the office setting or a sleep lab titration if adjustment settings are needed. For daytime respiratory failure or severe impairment, we we recommend going straight to the portable ventilator. The key feature here is that the ventilator is portable, meaning that it's battery operated. So if electricity is a problem, these devices can support respiration. One feature about both of these devices is that they have remote data monitoring. So the data is recorded and captured on a secure cloud, and the provider can actually log in to check on the patient to see what the usage is like, if there's any leak issues, pressure ranges, respiratory events. So if a patient is doing well and stable and calls me and says that, I'm not feeling well, I'm having more short of breath, I might be having an infection, some of these parameters will change, and I can actually look and determine how severe they are. In terms of airway clearance recommendations, again, I can't stress enough the benefits. It's lung volume expansion. Of course, also improves drainage of secretions, and by doing that, it prevents respiratory infections such as pneumonia, and also can prevent tracheostomy. There are three options. There is a manual or mechanical cough assist. Also, there is the percussive, which is the vest therapy. And the vest should not be used alone because you can mobilize secretions into the larger airways, but these patients have weak cough, so they can't cough it up, so it can cause a mucus plug. So it's important if you're going to use a vest, you need to use it with the mechanical cough assist. And also the nebulizer therapy. This is a lot of times used for an acute infection. In terms of cough assist techniques, there are three options. You can use the self-inflating bag, which is the Ambry bag as we know it. And this is, we use it and we call it breath stacking. The other one that we know very familiar with is mechanical inexsufflator, which is a cough assist device. This is one of the devices here. And then we also can use the ventilator in a volume cycle mode. And this is not BiPAP. It has to be a ventilator. And in the volume control mode, we can use the mouthpiece and we use breath stacking so that we can accumulate air into the lungs. And this, because of the higher lung volume, the elastic force can cause a greater airflow during a cough. Also very important to prevent aspiration. So it is, I understand it's difficult for patients to sleep in a semi-upright position, but if you can, it would be very beneficial. Also good daily oral hygiene practices. And we can try to reduce aspiration risk with changing food consistency, speech therapy, airway hydration, and oral suction devices. And it's important to plan for illnesses, emergencies, and anesthesia for certain procedures that's required. So in the home setting, we should, the patient should have an individualized care plan and also know what is the criteria or threshold for presentation to the emergency room. And also good communication with the EMS or acute care providers so that if you are transported by EMS, they know your needs, advanced directives, and care protocols. In the hospital, it is important to bring the home equipment. Even though the hospital may not let you use it, it is still important that in case some hospitals don't have the equipment that you need, other hospitals may allow you to use it. Try to go to a tertiary care center where the expertise is there. And I really recommend that that patients really try to have caregivers stay with them. In terms of anesthesia, again, tertiary referral center is better if possible. The difficult airway evaluation by the anesthesiologist. So having anesthesiologists who understand SMA would be much more beneficial. Anesthesiologists should be using capnography doing a procedure with anesthesia. This is basically monitoring CO2. Minimize sedation, anesthesia, and opioids as much as possible, and then also provide aggressive secretion clearance management during the pre and post procedure. And again, avoid excessive oxygen supplementation without concurrent non-invasive ventilation. So in summary, these are the recommendations for non-sitters, sitters, and walkers. So for aspiration prevention, we recommend immediately for non-sitters, for sitters if they have swallowing impairment, and for walkers only if symptomatic. For mechanical airway clearance, for non-sitters immediately. For sitters, if they have an ineffective cough or their peak cough flow is less than 270 liters per minute. And again, for walkers, if they're symptomatic or evidence of a weak cough. For non-invasive ventilation, again, for non-sitters, we recommend it immediately. This is a proactive approach. And then for sitters, if they have an abnormal sleep study, if they have symptoms, and if they're hospitalized. For the walker, so if they have a abnormal sleep study or if their FVC is impaired. Now, it is also critical here that the sleep study is really important during a pre-op assessment for a procedure, because they may have a normal FVC during the day, but during sleep, they may have evidence of hypoventilation, hypoxemia, especially during deep sleep or REM sleep. And this is where they will get into trouble if we don't know it. So it's important to do a sleep study and initiate NIV if the sleep study is abnormal. And these are the immunization recommendations you can see here as well. And I think that's it. Thank you.
Well, welcome. Glad to be presenting here with Sarah today. We're going to be focusing on the nutrition care for non-sitters. And as such, we're going to first go over the standard of care recommendations, then just some general diet considerations and formula tube feeding, and then a couple of case studies, one with an infant with early diagnosis and one with an older patient on therapy. So first of all, going into our standards of care. So this middle column right here is what was outlined for non-sitters in the consensus standard of care that was published in 2018. And I do want to note that, as many of you are probably aware, is that this consensus statement came out before FDA approval of Spinraza. At this point, when these discussions were being made, it was in trials, in clinical trials. And so I have added onto this last, we have added onto this last column what we're seeing now. But I just wanted to be very clear that this is not part of the consensus, just the middle column. So initially, swallowing is our ultimate concern for children with SMA. So typically, when a child is diagnosed with SMA, this was based on symptoms. And so because of this, we recommended a modified barium swallow study right at diagnosis. And usually at that time, we recommended this as opposed to just maybe a feeding eval, because we saw a lot of silent aspiration in these kiddos back then. And so right away, we would have some aspiration issues, some reflux, and so, sorry about that. And so we would go right into a nasojejunal tube if they had an unsafe swallow. I can only think of a small handful of times that I had a non-sitter with SMA historically who was considered safe to swallow. And so we would put a nasojejunal tube in until we could get them scheduled for a G-tube surgery. And also, standard of care at that time is if you did have somebody who could safely swallow, that we most often needed some feeding therapy and some modifications, not only with the nipple, as well as maybe some changing of consistency of the formula or milk. And with our newer therapies right now, we're all kind of playing this by ear because it is newer to us. But with newborn screening, if we're catching them kiddos early enough and we're able to treat them right away with some of the therapies, we're usually only doing a modified barium swallow if there are symptoms. So coughing or choking with feeds, increased respiratory illnesses, those are all things that taking a longer time with feeding or fatigue with feeding. If we had those symptoms, then we would do a swallow study. But if there's no symptoms, we just generally do a feeding eval. And obviously the same situation in that if they were considered to be unsafe to swallow, we would put in a feeding tube. I think the main difference to us at this point is that, is that if we, the main question that we have right now is if we find that a child is unsafe to swallow, or whether we put in a nasojejunal tube until we can get the feeding tube in the long-term feeding tube in place, or if we're going to do a nasogastric tube. And we generally look towards if the child is having some reflux and additional aspiration concerns, and that will help us to decide placement between an NJ versus an NG while we're waiting for the feeding tube surgery. Nutritional intake, we just really look at calorie needs based on growth. And so we look at this over time. This was the consensus, because just one look at the feeding tube, one look at the feeding tube, and one look at the growth curve is not enough time. And we determine this because we generally will have children quite low on the growth chart, so maybe less than the 5th percentile, that are growing well and look appropriate. And as long as they're following that curve and you can physically look at them and see that they have adequate fat stores, there's really they're really doing okay. And so that's why we need to look at it over time. One thing that we also look at is for calorie needs for kids with newborn screening and therapies. We generally look at, for when we're determining calorie needs, work of breathing and whatnot. But what we have found with earlier start with the newborn screenings and therapies is that we're finding that the calorie needs are more closely matching, calorie needs of a healthy child. And I talked about growth monitoring. So then onto the acute care. For our consensus statement, we were pretty firm to limit fasting to less than 6 hours when ill, and to really be sure in those acute care situations to monitor electrolytes, glucose, and fluid. Now, we still recommend fluid and monitoring during illness for a child or adult with SMA. But the fasting time may be extended, and really that fasting time at this point depends on the relative health and nutrition stability before being in acute care. So if you had somebody with adequate fat stores and really, good nutritional status before, able to, bolus feed or have physiologic feeds versus continuous feeds, they may be able to go longer. If you have somebody who is on continuous feeds, though, probably you're closer to that 6 hours when ill. For GI constipation, reflux, constipation, vomiting, dysmotility are all very common with people with SMA. And so just make sure that when you're seeing a patient that you're asking these questions, documenting it. We generally treat this, making sure they're adequately hydrated, and then with medication because it is a concern. With newborn screening and therapies, we're finding this unchanged. Symptoms may be less severe, but you still need to be sure to ask your patients. We recommend a dietitian evaluation for kiddos every 3 to 6 months, maybe more frequently if they're having feeding, swallowing issues or on a feeding tube to help adequately adjust for their growth. Annually for older kids and adults. For bone health, we want to optimize calcium and vitamin D, and that has been unchanged. And for labs evaluations, we recommend, we often see, and this is a problem generally in the population, especially northern climates, is to get a 25 hydroxy vitamin D level, and then other nutrition labs is indicated. So indications based on nutrition focused physical exam, or just checking their intake and seeing that maybe they might be a little low in a vitamin or mineral. You may consider taking a lab. Okay, so for general diet, I did say we want adequate calories to promote growth for kids and maintenance for adults. Everybody is different, and especially with the therapies and the continuum of symptoms of SMA, you want to treat it individually to the patient, to their growth. Dr. Mehta had kind of looked at, indirect calorimetry as the most optimal method. A lot of people don't have access to that. And so what I recommend is just go from, either use the WHO standard equation, use the Schofield equation, I generally go between, like 9 to 11 kcals per centimeter in older kids. You go from there, and then you make adjustments to promote growth. There's no difference in protein or fat or micronutrients than there would be with the general population. We've had no evidence to indicate that different dietary reference intakes were needed. We did, want to maximize to try to get, as close to your bone health nutrients as you could. One thing that is different is that with increased sweating and secretions and increased respiratory losses, we can see maintenance fluids. We can see fluid needs up to 150% of maintenance in that situation. I do want to just say a little tidbit on fats. This is no different than we would normally recommend for a healthy individual. There, of course, are minimum fat considerations for brain growth and eye development in young children, and we want to provide enough fat to prevent essential fatty acid deficiency. For formula and tube feeding considerations, we typically will see this in non-sitters. If you're having a formula, of course, with all the immune factors and great components of human milk, it is preferred. If you are using formula, we really recommend, especially now with therapies and treatments, that you start with an intact formula and then you go to a more broken down protein formula based on how well they're tolerating it. So you go from an intact to a hydrolyzed. We do skip out soy. We don't even look at soy in this process, just because there is an allergy that's behind the intolerance that soy would also probably be on that same scale. So we went, from an intact formula to more hydrolyzed formulas all the way to an elemental formula. I do want to say a little something about the amino acid diet. You may have heard of this. It is a diet that consists of elemental formula with supplements and additional blended fruits, vegetables, juices, and fluids. It is typically lower in fat. There is no strong evidence, and there has not been any studies of the amino acid diet. There have been family reports of improved symptoms, but the standard of care consensus on the use of an amino acid diet was divided. I just want to give some considerations for this diet. I do see it needed less often. We usually go with this range of formula use, and I find that we are not needing to go to an elemental formula for tolerance with our kiddos who are caught early and on adequate therapies. And you just want to use real caution, because there is a chance of having inadequate nutrition intake on that. Tube feeding administration, if we have a kiddo on tube feed, historically a non-sitter, you're pretty much continuous tube fed, and that is another reason why we typically recommended a Nissen fundoplication with a G-tube, just because you're on continuous feeds and you have all of your respiratory care going on. But now with therapies, we're actually moving towards kids who have abnormal swallow and needing a feeding tube. We're moving towards more physiologic bolus feeds as those are tolerated. Okay, so on to a case study. This is a non-sitter infant male diagnosed with newborn screening. And newborn screening, they saw a slight head lag with this young boy, and he was treated with nusinersen. At 20 days old, he was admitted to the hospital with an aspiration event. At that time, we placed a feeding tube. He was growing weight on the 53rd percentile, weight for length on the 71st percentile, looking, pretty adequately, fed, fluffy enough for a dietitian. He's on an intact formula, about 20 kcals per ounce at 27 mils per hour over a continuous feed. I won't go too much into the calories except for to kind of note some historical differences. Usually we could not, historically, for a kiddo who was a non-sitter, we wouldn't be able to do a standard formula continuous and get all of their needs in. We wouldn't be able to get the volume. There was a volume tolerance issue. So right away you can see in this kiddo there was no volume tolerance issue. We did not have to fortify the formula. At 2 months of age, he was still on continuous feeds, weight tracking at the 53rd percentile. His rate had gone up a little bit and we were able to step back a bit from continuous feeds. You'll see that his calorie needs went from 105 kcals per kg to about 87. At this point, he was a little bit, young infants, I like to be closer to the 2 grams per kilogram. So at this point, we added a protein modular and we decided to trial a move to an NG tube to see if he could tolerate that. At 3 months of age, we found the NG tube was tolerated, so we were able to slowly increase the rate. At this point, close to 4 months of age, he was dosed with Zolgensma. His rate at this time, we had gotten an increased rate to 43 mils per hour over 18 hours, still with the standard intact formula at the 20 kcals per ounce, which is remarkable to me. Usually, historically, at this age, I'm having to concentrate feeds because of some volume tolerance issues, and that strongly goes towards therapies. There was concern for rattly sounding breathing at this time, and so we wanted to proceed really slowly with advancing his feeding rate. At that point, at 5 months of age, he had gone down in his time on the tube and was able to start taking taste of baby food for therapy. His weight was still tracking at the 50th percentile, which is about where we wanted him to be. Just based on his nutrition-focused physical exam and looking at his appropriateness in person. You really can't go on a growth chart sometimes on this, especially for people with SMA. At 7 months of age, we no longer had concerns for rattly breathing. That had pretty much resolved. We were increasing more purposefully towards bolus feeds. His growth had jumped to the 69th percentile at this time because he was able to take a little bit more by mouth for therapy, doing really well. Fully anticipates that this child may not need to have a feeding tube to meet all of his needs at this point. We'll start backing off somewhat, and the tube feeds will start becoming more supplementary at this point. And so this kid is a 13-year-old male with SMA type 1. He was diagnosed based on symptoms. And really, I think that this goes through our historical history of kids with SMA, in that he was diagnosed based on symptoms at 5 months. At 7 months, he got an NJ tube, 8 months, a G tube. He's had, several spinal rod surgeries and expansions and vector expansion surgeries. He is on respiratory support of BiPAP. At 17 months old, when I pulled this data to do this case study, I was like, well, this makes me look like a really bad dietitian, because at 17 months of age, he's at the 50th percentile, and now he's tracking weight at the 3rd percentile. And this just really goes to show you how you really have to look at them in person and not just on a growth chart, because he is actually, his mother actually contacted me this week because she was concerned about him getting too overweight. But we determined no, he's following his curve. He's looking well, just because you really want to make sure there's adequate fat, but you don't want to overdo it. On the stores, he is getting feeds of peptide-based formula and water, and he's had these same feeds for the majority of his life. At 28 months of age, he did trial an amino acid diet. He was too lethargic on this diet, and so we decided to take him off it. At 3 years old, he was on a blenderized formula with a peptide-based formula as the base, and he did get nusinersen at 9 years of age. I think the remarkable thing at getting nusinersen at 9 years old is, I want to say that his calories we would maybe increase them 5-10 calories a year for him to remain stable. We were really monitoring his vitamins and minerals and fluid needs. But after treatment, we really had to pack on those calories and get in some more calories and protein we were finding. He really started to move more, manage his secretions a little bit better. I think that he will probably remain on a feeding tube for the rest of his life, but we are now working to increase his ratio of blenderized formula to peptide-based formula so that he has more of the blenderized formula, and to just continue to monitor his calories and growth and make sure that he remains, appropriate on his growth curve as he gets older. Okay, I'm coming to the end of the presentation. I just wanted to kind of go over some basic resources for SMA care nutrition supporter on this list. I will say that I strongly recommend that all kids with SMA, non-sitters and sitters and walkers, are referred to a dietitian. And if there are any issues with feeding or swallowing, that they're also seeing an SLP or an OT. I have included Sarah and my contact information for any clinician questions if you have any. And now I think we have a few minutes to have some questions if there are any questions from the audience.
Yes, it doesn't look like there's any yet in the Whova app, but feel free to write in anything you want to ask us. We do have a little bit of time left.
It looks like one just came in. You mentioned that simply following body weight on growth curves can be misleading. Can you imagine any better means of measuring?
Oh, very good question. And I neglected to say that, what I do. So what I do is I will actually do a mid-upper arm circumference in my kiddos, and I track that over time. We used to, and this was part of research, collect a DEXA scan every year as well. We no longer do that. But if you have some other way to assess body mass, lean body mass and body fat, that would be great. I find that an inexpensive way is the mid-upper arm circumference. If I'm really concerned, I'll also do mid-upper arm circumference in conjunction with a tricep skin fold measure. Those are pretty inexpensive to do and track over time.
Yes, I would agree. I also wanted to add that I think one of the easiest ways to kind of monitor growth in kiddos that don't fit the normal curve is to just keep a close eye on their pattern and their growth curve, which Becky did mention. But it's definitely more subjective, which certainly makes it kind of difficult to monitor that. We have another question. Did you want to add to that?
Well, I was just going to say there was some point in time that we were really strongly discussing whether we needed a growth curve, a growth chart for SMA, but there's just such a diversity of symptoms, and people right now that it really does, have to be individualized. You get somebody at the 50th percentile, non-sitter, there is a high likelihood that they may have maybe excess fat. So you just really want to make sure that you're doing that visual exam and looking at them for fat stores and appropriateness of fat. If you're starting to get a kiddo with getting a belly that's more than just a normal fat amount, you probably want to start modulating that.
That's a slightly good segue into this next question. Some parents discuss fatty liver disease and SMA. Do you think that's part of SMA or more a reflection of diet?
That is a really good question. So I think that I can't say for sure that there isn't something related to SMA that may cause issues with fatty liver. But I will also say that some of the more recent posters and papers about fatty liver, those kids were usually on an amino acid diet, and those diets are really high in carbohydrates. like 80%, 85% carbs. And so that may also play a role in fatty liver for that. But there could also be something related to SMA that we just don't know enough about. And so I would just say we really want to keep an eye on not having excessive carbs in the diet, because that, you know, in relation to fat and protein, and that can definitely cause some fatty liver.
Yeah.
Did you have anything to add to that, Sarah?
I was going to say that the patients I've had with that issue have been on an amino acid diet. So it's certainly a matter of educating the parents and making sure that they understand that a high carb diet can cause fatty liver disease, which a lot of people don't know or understand. So I think making that clear and then working with the family to come up with a better balance that everybody's happy with in terms of macronutrients is really the only thing we can do from a diet perspective.
Great. Yeah. And the one other thing that I would tack onto that is that we do cholesterol panels so that we can see if we're getting some elevated triglyceride levels. I think at one point, just historically, I had a mom who was on an amino acid diet, but was on a higher fat one, wanting to move to a different formula that was historically low fat. And so I said, okay, you know, if this is really what you want to do, why don't we go half and half, and we'll take some labs before and we'll take some labs after, and then we'll decide what to do. And in that circumstance, we saw that just changing to the lower fat, higher carb diet, their triglyceride levels went very high. And so the mom and I were able to mutually come to a decision of doing somewhere in between to help moderate that, so that we didn't have excessive triglyceride levels.
Another question: what factors are going into consideration on whether a non-sitter with modern SMA therapies gets a G-tube only or a G-tube and a fundoplication?
Yeah, that was so the one kiddo from my example has not gotten a G-tube yet with the Nissen, and there was a real conversation between us about whether this kiddo actually needed a Nissen or not. I think, knowing what I know now, I would probably say for this particular kid, no. I think that the Nissen probably should come into play if you if there's a lot of concern for aspiration. I think what you're looking at is an aspiration concern to doing a Nissen. Would you have anything to add, Sarah?
I don't know. I think you covered that pretty well.
Any other questions?
Looks like we got them all.
Okay, great.
Good timing.
Well, thank you everybody for your time and attention. We do have our email addresses at the bottom of the screen if you do have additional questions.